Hi everyone, how you doing today? It's Dr. Adeshina again from ftplectures.com. I'm very excited because I'll be talking to you today about cranial nerves. I love cranial nerves. Oh boy, whew, it's the best thing ever. They're so easy to memorize. We're going to break it down and simplify it for you as usual. Now, I love mnemonics, and we're going to learn these beautiful mnemonics that you will never forget. I promise you, once you learn this mnemonic, game over. All right? So, now, we know there are 12 cranial nerves, correct? There's 12 of them. So, since there are 12 of them, we're going to have to put a mnemonic on the board. So, I'm going to break this board into 6. So, the first 6 is going to be here, and the second 6 is going to be here. Now, 1, 2, 3, if you can count, 4, 5, 6. Let's go here. 7, 8, 9, 10, 11, and 12. Wow, look at that. 1 to 12. Come on, guys. Don't tell me this is not easy. You should be able to know 12 stuff. You can count 1 to 12. This is easy. Yeah, but med school never does that. They never make it so easy for you. So, that's why I'm here. So let's learn the mnemonic. And the mnemonic goes like this. O, O, O. To touch and feel a girl's veil, such happiness. Let's check that out. I said O, O, O. To touch and feel a girl's veil, such happiness. You can change the veil with violin, any V word you feel comfortable putting it. But the point is, can you imagine, oh, 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 to touch and feel a girl's veil? Not a lot of people get to touch a girl's veil. If you get to, good for you. You feel such happiness. Well, if you remember that, that's pretty much it, guys. Now, let's put in what we need to actually know as medical students, nursing students, healthcare professionals. So this actually makes a lot more sense. And I'm going to put some clinical pearls because that's what I do. So this is just not a memorization routine. You actually know what patients present with when they have a dysfunction. It's going to be a little bit of neurology inserted into this lecture. It's kind of like, let me get a little tea with toast, please. That's right. So the first nerve, which has O, is known as the olfactory nerve. Olfactory nerve. And the next nerve, which is the O, is the optic nerve. The second O, right? O, O, O is oculomotor nerve. T stands for trochlear. The trochlear nerve, okay, to touch and, okay, so O, 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 we've got, and number 5 is trigeminal. The trigeminal nerve is the 5th nerve, okay, and is abducens. Abducens nerve, number 6. So we've got O, O, O to touch, and let's feel. In order to feel, that's the facial nerve. The facial nerve. And number 8 used to be known as the auditory, okay? That's why it's A and, okay, feel a girl, but since we don't call it the auditory nerve, like your mom would probably know the answer to that, okay? So we don't want them to know, so we call it the vestibulocochlear nerve, because it has the vestibular nerve and the cochlear nerve, which is for hearing. We're going to talk about it later, right? That's the vestibulocochlear. So you have to remember that. Number 8 is auditory, but the new name is the vestibulocochlear nerve. And the G is the glossopharyngeal pharyngeal nerve. That is number 9. That's the girl. Okay? And number 10, the veil, is the vagus nerve. The vagus. I like that. Vagus nerve. It's kind of making a statement. Okay? And S, which is number 11, is the spinothalamic nerve. The spinothalamic nerve. Okay? I'm sorry. I take that back. The spinal accessory nerve. The spinal accessory nerve. That's no spinothalamic nerve. My apologies for that. That is the spinal accessory nerve, which we're going to talk about. And the last one is the hypoglossal nerve. A hypoglossal nerve. And that's it, guys. Very, very straightforward. O, to touch and feel a girl's veil. Oh, such happiness. Okay? All right. Now, what does this all mean? I'm not just going to give you a mnemonic and just walk away. This is neurology, baby. Let's make it a little bit more simple. Olfactory stands for the nose, right? That allows us to smell. That's the function of the nerve. So if a patient has a damage to their olfactory nerve, they develop anosmia. Anosmia. So anosmia. So it means they cannot detect smell. That's it. That is very, very straightforward, guys. That is the first nerve. The second nerve is the optic nerve. Optic for eyes. So we need our eyes to see. Oh, jeez, it can't get more. Can this get a little bit more easier than that? No, it can't get more easier than that. So what happens when people have a damage to their optic nerve? I think my 5-year-old brother can tell me that answer. Well, if your optic nerve is knocked out, patients are going to have visual field deficit. They're going to develop anopsia. Anopsia, okay? They're going to have visual field deficit. And they can also have loss of the light reflex, especially with cranial nerve 3, okay? Loss of light reflex. Because the cranial nerve 3 could also be affected, so you should know that, all right? So, now, the third nerve, which is our oculomotor nerve. Now, the oculomotor nerve innervates about 6 muscles in our eyes. Ooh. Let's see. Well, these are very important because they help the medial rectors. We're going to need some space then. All right, let's create some space. We will be back to 5 and 6. So this is the eyeball. Okay, let's make this very easy. All right, let's draw a line. That's a muscle. It's another muscle that goes this way. It's another muscle. This is the eye, okay? So the muscles that are attached to the eyeball, there's one. This is the nose. So this is the medial aspect, and this is the lateral aspect of the face. So there's this oculomotor nerve is responsible. It's responsible for the medial rectus muscle, and the medial rectus muscle pulls our eyes away, right? So it pulls it to the middle. That's why it's called the medial rectus. So when I look this way, for me to be able to look that way, see, this eye goes all the way to this corner, and this guy in the middle is not right close to my nose. Well, that is the medial rectus muscle working under the influence of the oculomotor nerve. So the oculomotor nerve innervates all the muscles of the eyeball except 2. Which one are the 2? The lateral rectors. The lateral rectors muscles on the lateral side of my eyeball. It pulls my eyes laterally this way. So let's look this way. Oops. My eye is right there. Oh, the oculomotor is not responsible for that. There's a different nerve that innervates the lateral rectus, which is the abducens nerve, number 6. We're going to talk about him later. We're going to talk about him later. And the superior oblique. The superior oblique. The superior oblique is on top of the eyeball. So the oculomotor nerve, its job is to elevate the upper lid, right? So when I look up like this, and when I look down, allows me, usually affects the levator palpebrae muscles and constricts my pupil. So when I shine light to a patient's eyes and the pupil constricts, that is under the influence of the oculomotor nerve. But it's like a reflex, okay? Cranial nerve 2 picks it up, sends it through 3, and 3 then constricts my pupil. That's why we always shine light in people's eyes in medicine. We are testing for cranial nerve 2 and cranial nerve 3. Also, accommodation. So when you tell the patient to have an H in space test, when the doctor pulls his hands like this, goes up, down, across your eyes, and you got to track this, my finger, and bring it to the middle. When you do the H in space, we are testing all our oculomotor nerve. And when you converge the two eyeballs in the middle, that is known as accommodation. Accommodation is the ability of the eye to be able to perceive objects both close and far away, okay? So when you bring it closer, the eye kind of goes into the middle like that, and when it goes away, because the object is much, much further away. Now, what happens when you damage the oculomotor nerve? Where patients develop diplopia. Diplopia. Di means two, plopia, okay? That means they have double vision. Why? Because the medial rectus muscles is not working very, very well. So the patient sees like they're seeing double, which is not good, all right? And they can develop external strabismus. External strabismus. Well, let's take a look why they develop external strabismus. Let me draw two eyeballs out for you. Here's one eyeball, here's the other eyeball. Here is the nose, okay? Here's the eyes, here's the eyes. If the oculomotor nerve is damaged, and remember, its job is to innervate the medial rectus muscle, which is right here. Its job is to pull the eyes into the middle, okay? Now, if you tell the patient to look this way, the patient is gonna look this way, and their eyeballs will be right here, okay? Because the lateral rectus muscle is innervated by the abducens nerve, okay? The abducens nerve is gonna pull this one, but I got bad news for you. This eye in the middle is gonna stay because it cannot, the rubber band cannot tug it into the middle, so it's gonna stay like that, okay? As you can see, normally the eye should be here, like the eye on the right, okay, should be here, and the one on the left should be on the other side, but it's gonna stay in the middle. If both are damaged, the lateral rectus will pull over here, and this will stay in the middle, okay? So that is known as external strabismus because they have the eyeball tracked to this side, but this is staying in the middle. Also, they can lose loss of parallel gaze. They can also develop ptosis, P-T-O-S-I-S. Ptosis is drooping of the eyelid, okay? Horner syndrome is a classic, but they can have drooping of the eyelid because the levator palpebrae superioris is innervated by the oculomotor nerve, and once you knock it out, guess what? You tell them to lift the eyeball open like this to open their eyes wide. No, it's gonna be a little droopy on this side, and the other side will be able to go up. That is a damage to the oculomotor nerve. Also, if these patients can have a dilated pupil, okay, the dilated pupil, and let's see what a dilated pupil looks like. Okay, so you look at the patient's eyeball, and the pupil is this big. But there's a bunch of things that can cause your pupils to be big, like drugs. But if it's a neurologic damage and the pupils are blown out pupils like that, it's because the cranial nerve 3 is damaged. Patients that have huge hemorrhagic stroke can get honcal herniation and can cause unilateral dilated pupil on one side. And the reason is because the ciliary muscles, okay, the ciliary muscles that constrict the eyeball to bring it into teeny small size, well, they're knocked out, and then the pupils just look this big. So you shine light on it. The afferent part of the cranial nerve 2 picks it up, but the constriction doesn't get to the cranial nerve 3, so their pupils are huge and dilated. And then they will also not be able to have a convergence reflex, okay? Reflex, okay? All right, so that's all you need to know about cranial nerve 3, okay? Cranial nerve 3. Let's talk about cranial nerve 4, the trochlear nerve. What does the trochlear nerve do? Well, it is a motor nerve. And that I didn't tell you about because this nerve, there could be, some are sensory, some are motor. And we'll talk about later during the lecture, okay? So, the trochlear nerve is a motor nerve that innervates the superior oblique, and its job is to depress and abduct the eyeball. Abduct the eyeball. So, trochlear nerve actually allows your eyes to go this way for abduction, so as is the lateral rectus muscle, which also allows you to abduct. But the trochlear depresses the eyelid. Depresses the eyelid. So what happens when you knock off the trochlear nerve? The patient is unable to look down when their eyes are adducted. So if their eyes are looking this way, they can't look down. Like if they're walking down the steps, the patient cannot look down because the trochlear nerve is damaged. These patients also have difficulty reading or going down the stairs, like I said. So what they usually do is they tilt their head away from where the lesion is. So if their eyes is damaged this way, on this side, they tilt their head away so they can be able to kind of compensate for this defect. Number 6 is abducens nerve. Abducens nerve is a motor nerve, like I told you, innervates the lateral rectus muscle. Abducts the eye, so the eye goes this direction, but unfortunately, if the patient has a damage to the abducens nerve, actually we haven't talked about 5 yet, so I'll come back to it. 6, the abducens nerve. These patients develop internal strabismus. And internal strabismus, if you look at their eyeball and you tell them to look this way, well, because the lateral rectus is damaged, the eyes is going to stay in the middle, but this is going to go this way, okay? Because the lateral rectus muscle is not working. Okay, that's internal strabismus. Internal strabismus, okay? And this is going to pull this way, so their eyes will be looking this way, okay? Let's talk about cranial nerve 5. Cranial nerve 5. Well, cranial nerve 5 is broken down into three categories. There's the V1, V2, and V3 branch of the trigeminal nerve. V1, which is part of the frontal part, the ophthalmic branch, that's what it's known as. V2 is known as the maxillary. This is where your maxillary is. And V3 is the mandibular nerve. So usually when patients, for the V1 branch, patients usually get, if you touch the patient's head with a light touch and pain and temperature of the forehead and their cornea, that's all V1. You knock that off, what happens? The patient doesn't have any sensation on their forehead. So if you're touching the patient's forehead, like, I can feel that, doctor. I can feel the site V1 is knocked off, okay? Or if you try to touch their eye and they don't blink, that means the sensory branch of the blink reflex with cranial nerve 7 is damaged. Cranial nerve 7 with cranial nerve 5. So cranial nerve 5 innervates the cornea. So when you touch somebody's cornea, they should blink because cranial nerve 7 should also allow them to blink. All right, V2, maxillary branch. Remember, this is the maxillary, guys. Maxillary, just general sensation over the palate under the tongue. You see that? That's the palate and the nasal cavity and the maxillary teeth, all right, the upper part of your teeth. Now, if you lose sensation to the maxillary part, very easy, V2 distribution is out. So if the patient can't feel their upper teeth, that's a V2 nerve damage. All right, that's the lesion, and that's how you isolate neurologic deficits. V3 innervates the general sensation to anterior 2/3 of the tongue. So if this is the tongue, and you break it into two, the anterior 2/3 is innervated by V3. The back of the tongue is innervated by a different nerve, which is the facial nerve. We'll talk about that when we get to number 7. But hey, guys, we're not done. There are muscles of mastication. Exactly. When you chew, the muscles of mastication, right? You got the pterygoid muscles, the masseter, they're all sitting there like, taking a bite of that hamburger or on that steak. Well, you're using V3 branch of the trigeminal nerve. The temporalis muscle, which is right here, the huge temple, you can feel it when you're chewing. It's actually always contracting. And also the masseter, the medial and the lateral pterygoids, plus the anterior belly of the digastric muscle. The digastric muscle is right here, right under your platysmus, okay? And the mylohyoid and the tensor tympani and the tensor pallidi muscles are all innervated by V3. So imagine if a patient knocks that out, if you lose V3, you're not going to be able to have sensation to your mandible. So you're like, Doc, I can feel this. Well, V3 is out. And then they come in and the patient says they can't feel their teeth. Oops, that is V3. Or the patient has jaw deviation towards the lesion. So there's two branches, right? There's two trigeminal nerves, V3 coming outside. Okay, so remember, if one is knocked out, they will have deviation to the side of the lesion. They're going to have a deviation towards the side of the lesion. So if the lesion is on the right side, the tongue will be deviated this way. If it's damaged this way, the jaw will be deviated that way because this side is weak and this guy is only working. Okay, and that is trigeminal nerve. All right, guys, we're not done yet. Remember, we're not just going to memorize mnemonics because I want you to be able to know this stuff cold. Let's go to the next nerve. Now we're done with number 6. Let's go to number 7, the facial nerve. It's facial. Okay, facial nerve. Now, facial nerve are responsible for the muscle of facial expression. Wow, that's rocket science. I'm surprised. Yeah, duh, it's called facial nerve for a reason. It innervates the muscles of your face. Okay, so let's talk about that. What muscles give you nice facial expression like smile for the TV? Hello, hi, nice to meet you. Yeah, those nice little facial expression that we make when we're mad, or when we're happy, or when we're sad. Those muscles of facial expressions are innervated by our facial nerve. And these nerves includes the orbicularis oris, the muscles around the eyeball. That makes you like look at someone like, I like that jewelry. Yeah, you see how you make that eyeball? That is facial nerve 7, guys. Okay? The next muscle is the platysma, okay? Then the orbicularis oris, the oral, the mouth. The orbicularis oris muscle, all right, it's innervated. That's what allows you to move your mouth and kind of make all this nice little funny mouth, movements, all right? That's all facial nerves. And the platysma, the thin muscles, like that wraps right under the submandibular area and just comes down like that, that is all innervated by cranial nerve 7, guys. And then the buccinator and the stapedius muscles. Stapedius muscle are all innervated by number 7. Now, in order for you to taste stuff, the tongue is very interesting. The anterior 2/3 is innervated by the trigeminal nerve, the V3 branch, but the posterior 2/3 of the tongue and the soft palate, okay, of the tongue is innervated by the facial nerve. So you got 2 nerves innervated in the tongue. That's very, very, very special. Now, also for salivation, in the patient to be able to salivate, 7 is also responsible, especially for the submandibular, okay, the submandibular and the sublingual gland, and the tear gland. So when people cry, they're using cranial nerve 7 too. When you see the baby crying like that, that's cranial nerve 7 that is using, and also making mucus inside the nasal and the palatal gland. So let's see what happens when there's a lesion of the 7th cranial nerve. Well, what happens is, whatever the site of the facial nerve lesion is, patient usually have like the corner of the mouth is going to be drooping, and they're gonna be unable to close their eyeball. They're not gonna be unable to close their eyeball, and they won't be able to wrinkle their forehead. See how I'm wrinkling my forehead, guys? See that wrinkle right there? That's all cranial nerve 7 that's working. If you tell the patient to wrinkle their forehead and one side is flat, oops, that is a facial nerve damage. And then because the buccinator muscles and all their masseter muscles are not working properly, they're going to have a facial drool. They're going to have a facial drool. Now, remember the facial nerve comes out right behind the parotid and basically spreads over the face like this. So what happens to patients, you can have a Lyme's disease that can knock out the entire facial nerve, and they will have unilateral paralysis and facial droop on one side of the face. If it is a cortical bulbar lesion where they have bilateral innervation, they're gonna spare the upper part of their face. So they'll be able to wrinkle, and then you say, oh, so they only have a facial droop on one side. That might be a cortical bulbar lesion. But if the entire facial nerve is knocked out from the outside, maybe like a huge parotitis that's huge compressing on the facial nerve, the entire half of the face is gone. Okay. They also have loss of the motor limb or of the blink reflex. So usually for somebody to blink and you try to poke their eye, the reflex is actually done by 2 nerves, cranial nerve 5 and cranial nerve 7. The ophthalmic version of the V1 component of V1 is where it picks up the sensation, but then for you to quickly blink your face so you don't get something stuck in your eyeball, especially when a fly starts to come in there, is done by cranial nerve 7. Cranial nerve 7, that's called the blink reflex. The stapedius muscle is inside the ears, all right? You have the malleus, the incus, and the stapes, those cute looking little small bones. Well, the stapedius muscle is hanging out on the stapedius, and it's innervated by cranial nerve 7. Now, the problem is if you knock out that nerve, you knock out number 7, they're going to have hyperacusis. Hyper means high, so you're going to be very, very sensitive to high sound. Okay? And then, because the posterior 2/3 of the tongue, the anterior 2/3 of the tongue is innervated by the anterior 2/3 of the tongue is innervated by the 7th of the tongue, and the soft palate is also innervated by the 7th nerve. Patient can lose sensation to their tongue. So if they can't taste anything in front of their tongue, you're like, interesting. Well, that's the facial nerve, guys. And then they can develop dry eyes. Remember, you need that for making tears, the lacrimal duct, right? So if you look at somebody's eye, this is the eyes. There's a lacrimal duct that empties out here. And this is the nose, okay? The lacrimal duct is also innervated by the facial nerve. So if you can't cry, you know 7th nerve is gone and the eyes is very dry. And they have decreased secretions also. And that's it. That's all you need to know for facial nerve number 7. Facial number 7. Let's go to facial nerve number 8, which is the vestibulocochlear nerve. Well, the vestibulocochlear nerve is a sensory nerve. And because it's used for hearing, that is function, and also allows us to maintain linear acceleration with gravity. And also angular acceleration when we turn our head. So when I turn my head like this at an angle, I'm not able to fall because I have semilunar canals inside my ears that allow me to balance, because I also have a cochlear. So unfortunately, when patients knock out the 8th cranial nerve, well, it's pretty easy. Oh, I can't hear. Huh? Say that again. What? Yeah, that's basically it. Sensory loss, right? Sensorineural hearing loss, because the cochlear nerve, which is needed for hearing, is damaged. Now, because our ears actually not just there to hear people's gossips and like, oh, what are they saying about me again? No. That's not just what their ears are for. They help you maintain balance. Okay, the ear is maintaining balance. So remember when I talk about that linear acceleration and also this angular acceleration, we need those. So once we lose the vestibular component, people start to lose their balance and they get vertigo. No, they don't spin around. They feel like everything is spinning around, okay, and they lose their balance. And they can also develop nystagmus. Nystagmus is when you take a pen and you tell the patient to look this way. And their eye goes this way, but then it keeps doing this. It's just like it's trying to force itself to come to the middle. The fast component of the nystagmus is what you always look at. So if it's going this way and it's coming to the middle, that's kind of medial, right? It's called medial nystagmus. Try to come back to the middle, okay? So that can show a damage. So if somebody has an acoustic neuroma or they have central vertigo, they can develop that also, okay? And that's the vestibulocochlear nerve. Remember, that is our auditory nerve. The next one is G, right? The G is the glossopharyngeal muscle. It's mixed. It has both sensory and motor innervation. And that's what allows us to innervate that oropharynx, the back of this pharynx, right? The pharynx is the back of the throat. Go figure, right? Back of the throat, the carotid sinuses, the carotid sinus and the carotid body. They pick up decrease in blood pressure sensation in the carotid bodies up here, so patients can develop syncope, all right? And also, they allow us to taste. It's responsible. The posterior part of the tongue is innervated by the glossopharyngeal nerve. So remember, the anterior part of the tongue has both the facial nerve and the V3 branch of the vestibule of the trigeminal nerve, but the posterior is the glossopharyngeal nerve. Okay, that's the posterior 1/3 of the tongue. So the motor part of it innervates the stylopharyngeus. The stylopharyngeus is right at the back of the corner of the mouth. It's coming off right where the eustachian tube is kind of diving down into the back of the pharynx. And also it innervates the salivary parotid gland. We all have a parotid gland. When mommy is cooking or you're smelling good food from a restaurant, oh, wow. I wonder where that good food is coming from. Salivating. Can I have a little bit of that? Yeah, that is the glossopharyngeal nerve at work. All right, guys. So when you knock that off, the patient loses their sensory limb and they lose the gag reflex. Okay, so the gag reflex requires cranial nerve 9 and 10. So when the doctor puts the little tongue blade in your mouth, and you gag or you're brushing your teeth, that is the glossopharyngeal nerve. Very, very straightforward, guys. Now, the next nerve is the vagus. The vagus nerve. Now, the vagus nerve is a big nerve. I mean, when I say a vagus nerve, it's a big nerve. All right? It has a mixed component. It has sensory and motor. And what does the vagus nerve do? Well, the vagus nerve innervates the muscles of the palate. The palate is the top of the tongue, like the top. That's the palate, okay? Except the tensor palati, okay, which is innervated by the 5th cranial nerve. Now, all the muscles of the back of your throat, which is called the pharynx, are innervated by the vagus nerve. But that is a big deal. So when I'm talking right now, I'm using my vagus nerve to talk because all the muscles, I don't care what the name of the muscle is. You know why? Because all of them are innervated by the vagus nerve as it tracks down and it's going down and going across and it's going to go into the belly and whatnot, innervated the intestine, it's going to wrap around the stomach, all that good stuff. But the bottom line is, except the stylopharyngeus nerve. The stylopharyngeus nerve is innervated by the glossopharyngeal nerve. So all the muscles of the throat, except stylopharyngeus muscle, is innervated by the vagus nerve. Okay, and remember, it innervates all the glands and the smooth muscles of your thorax, the gut, and the mid-gut. So what happens when the vagus nerve is knocked down? You got a lesion. Well, patient's gonna have a droop in their palate. Their palate is gonna droop, and the uvula. If you open your mouth, if you open the mouth, okay, and this is the tongue. The uvula is that little thing that you see, like a little bobby head, right? That little thing, that's the uvula. The uvula always deviates away from the lesion. So if there's a lesion on the left of the vagus nerve and the left is damaged, the uvula will deviate to this side because it's been contracted on this side. This part is paralyzed, so it gets contracted and pulled away from the center. If it's on this side, on the right side, it's gonna deviate to the left side. The patient, because it's the throat. Well, if the throat is what you use to swallow, the esophagus, right, uses the vagus nerve, patient's gonna develop dysphagia, difficulty swallowing. And you're gonna lose the motor limb of the gag reflex also. So when you put the little tongue depressor, they're not gonna gag because vagus nerve is gone. And also because the recurrent laryngeal nerve comes up the vagus and innervate the vocal cords. When there's a damage to the vagus nerve, this patient develops hoarseness and dysphonia. They start talking like this. Yeah, that is hoarseness. The patient cannot talk very loud because the vocal cord is paralyzed, okay? And also, the spinal accessory nerve. The spinal accessory nerve comes out and innervates the opposite side of the sternocleidomastoid. So the sternocleidomastoid, which is the muscle where you're looking at right here, that attaches to the from sternum, from the name sterno, like it splits up here right there by the clavicle and goes all the way and attaches to the base of the mastoid process. That's known as the sternocleidomastoid muscle. Well, what it does is it allows us to turn our head to the opposite direction. So when this contracts, my head can turn this direction. When this contracts, it turns my head to the opposite direction. So also it helps us elevate and rotate the scapula. So you want the patient to shrug their shoulders, they're using the spinal accessory nerve. So when you tell a patient to push against to one side and they have weakness on one side, you know that they have damaged their spinal accessory nerve, the spinal accessory nerve. And also if the patient has a shoulder droop or they have difficulty combing their hair, that's because they can't rotate their scapula over because they have damaged the spinal accessory nerve. The spinal accessory nerve has been damaged, okay? All right. And the last but not the least is the happiness. Happiness, we're going to be very, very excited and happy to hear that. This is the hypo, which is below the tongue, the glossal, the hypoglossal nerve. So what does the hypoglossal nerve do? Well, look at my tongue, see how it's moving around? That is the hypoglossal nerve in action. There's a bunch of muscles inside the tongue that's helping your tongue move all over the place. When people talk, you wonder what's moving, all right? So it innervates all the muscles of the tongue except the palatoglossus, which is innervated by the 10th cranial nerve, and the hyoglossus, the styloglossus, the genioglossus, and the intrinsic muscles, okay? So what happens when there's a lesion in the hypoglossal nerve, the tongue deviates and protrudes towards the lesion. So if there's a damage on the right, it's going to deviate to the right. If it's damage on the left, the hypoglossal nerve is going to deviate to the left. Now I'm going to summarize this by showing you a quick neuro exam of all the cranial nerves, starting with 1. So with 1, you tell the patient to smell because, oh, I smell that. That's peppers. That's cranial nerve 1. 2, can you see me? Wow, you just saw me. Great. That is cranial nerve 2, okay? And you want to check for cranial nerve 3, you take a pen light or you take your finger and you tell the patient to go into H in space. Hold your head still and follow my eyeball. Up, down, go across the eyeball, go up, down to the middle and converge. You just tested cranial nerve 3, 4, and 6. All right, let's check for cranial nerve 5. You check the motor aspect of the cranial nerve 5. Tell the patient to close their eyeball. Look at that. Well, that they can squeeze down. That's good. Let them smile. Oh, they can smile. That's good. You're trying to see cranial nerve 7 at the same time with that. You tell them, to bite down on their cheek. You can feel the masseter muscles. Very, very good. So all the muscles of mastication are intact. Very good. So you want to check for sensory in V1, V2, V3. Can you feel this? Yes. Can you feel that? Yes. Can you feel that? Good. V1, V2, V3. You check for cranial nerve 7. Tell them to close their eyes and don't let them open it. Very good. Open it as wide as you can. You can see the wrinkles of their foreface. Smile. You can see them smile. It's very, very good. All right. And then you tell them to stick out their tongue. So in order to test for cranial nerve 8, you do that. You can put a turning fork on both ears and you're like, oh, can you hear that? Yes, they can. So cranial nerve 8 is good. All right, cranial nerve 9, you stick out your tongue, you put a tongue depressor, you say ah, and you can say ah, you're testing for cranial nerve 10. If they're talking to you, the vagus nerve is working. All right, and cranial nerve 11, shrug your shoulders. If they can shrug your shoulders with equal strength on both sides, cranial nerve 11 is working. And cranial nerve 12 is hypoglossal nerve. Stick your tongue out. If your tongue is very deviated to one side, you know that's a problem. If you can keep it right in the middle, you just did it for the hypoglossal nerve. So, oh, to touch and feel a girl's veil, such happiness. All right, and that's all you need to know for cranial nerves in neurology. It's Dr. Adesina from ftplectures.com. Have a great day. Bye-bye.